Hello, everyone. Welcome to today's webinar, New Treatment Options for Uterine Cancer. We're going to wait just a minute or two for more people to sign on, and we'll be starting very soon. Welcome to anyone who just signed on. We'll be starting in about a minute or so. Hello, everyone. Welcome to the webinar. Just another minute to wait for a few more people, and then we'll be starting. Okay, I think we're going to get started. I wanted to welcome everybody to today's webinar, New Treatment Options for Uterine Cancer. My name is Kitty Silverman. I'm the Uterine Cancer Program Coordinator at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast and ovarian cancer for the last 44 years by offering the support of those who have been there. SHARE offers many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. This year, we're really excited to be adding a uterine cancer program, which includes a helpline, support groups, patient education. For more information on all of our programs, you can visit SHARE's website at sharecancersupport.org. This webinar is also a collaboration with the Foundation for Women's Cancer, which is dedicated to increasing research, education, and awareness about gynecologic cancer risk, prevention, early detection, and optimal treatment. For more information about the Foundation for Women's Cancer, visit their website at foundationforwomenscancer.org. All participants will be muted during the presentation. When Dr. Mueller finishes presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Now I'd like to introduce our speaker. Our presenter today is Dr. Jennifer Mueller, a gynecologic oncologist and assistant attending in the Department of Surgery at Memorial Sloan Kettering Cancer Center. Dr. Mueller helps lead the endometrial cancer research team at Sloan Kettering with an emphasis on prospective, translational, and collaborative efforts within and across institutions. Welcome, Dr. Mueller.
Thank you so much. It's such a pleasure to be able to provide this webinar as part of your series, Kitty. And I'd like to specifically thank the Foundation for Women's Cancer and the SHARE organization for their support and commitment to this really important cancer. So the title of my talk is New Treatments for Endometrial Cancer, a 2020 Research Update. A basic outline for everyone tuning in is that I will begin with some background facts on endometrial cancer, just a brief review, and then we'll move into discussions of treatment strategies and incorporate research updates in both early stage disease as well as advanced stage and recurrent disease. and I'll provide highlights from the Society of Gynecologic Oncology's 2020 conference. I'll end with a brief review of the future directions that research is going, specifically on clinical trials that are recruiting that we are anticipating results from. So by review of just the basics, endometrial cancer is the most common GYN cancer. It arises in the lining of the uterus. You can see here in the schematic on the right, the uterus itself has several different regions, and this cancer in particular arises in the lining. And in 2020, there will be more than 65,000 new cases diagnosed. The incidence of endometrial cancer is also increasing, and this is something that is obviously of concern to all of us as clinicians and researchers. And we do believe one of the largest risk factors may be the rising incidence of obesity across the globe, and in particular in the United States, as there is a connection between increasing rates of obesity and endometrial cancer. Most commonly, this cancer arises in women between the ages of 55 and 64, with a median age of 63 years old. But you can see from the bar graph to the left, we do see it across the lifespan, even in women under the age of 50. What is really important to emphasize is that over 2/3 of women will present with early stage 1 disease. And this is largely due to spotting, vaginal bleeding, that all lead to a biopsy that can confirm a diagnosis. So we do have some strategies to identify this cancer when it presents early on. It's also important to emphasize that patients who present in stage 1 uterine confined endometrial cancer have an excellent prognosis that approaches 95% 5-year relative survival. It's also important to remember, if you look to the far right on this bar graph, that when women present in advanced stage, here seen as distant disease, survival rates are not excellent at all. And this is an area that as researchers and clinicians, we are focused very much on to try and improve outcomes for women. We treat endometrial cancer generally using surgery as our mainstay of treatment. And Dr. Wright did an excellent job in the webinar earlier in 2020 on the 101 basics of endometrial cancer by reviewing why minimally invasive laparoscopic or robotic assisted surgery is now the standard of care for the vast majority of women with endometrial cancer. Surgery is important because it provides staging information. It tells us where the cancer has gone under the microscope, and all of this helps to guide next steps in treatment. We used to remove all of the lymph nodes. So maybe 10 years or more ago, we needed the lymph node status as part of staging, and all of the lymph nodes that are near the uterus in the pelvis, and some even above the pelvis in the para-aortic region, would need to be sampled to make sure that we, as best as we can, identify lymph node disease. Through the work of many important research in the field over the last 10 years, we now have incorporated as part of a standard of care in endometrial cancer, sentinel lymph node mapping, which rather than removing all of the lymph nodes in the area, we remove the lymph nodes that matter. So now women, when they have their staging surgery, are having 1 to 2 lymph nodes removed on each side, and that gives us all of the information that we need to appropriately stage patients. We'll move on now to the treatment of early stage endometrial cancer. So when we're talking with women who have already undergone surgery and we're trying to determine whether or not they need any additional therapy, we have to ask 2 important questions. The first is, are there any risk factors that put a woman at risk for a recurrence of her cancer? And in endometrial cancer, we have many different risk factors that we consider, and they're all considered, and they're often considered in combination when we try and determine whether additional therapy is needed. Among them is how old a woman is. We do know that as we increase in age, particularly age over 60, there is an existing risk factor for recurrence, as well as the grade of tumor cells, low grade or high grade, whether the tumor has invaded into the uterine wall, the inner half versus the outer half, whether something called lymphovascular invasion is present or absent, which is something we only can see under the microscope, as well as the stage of the cancer, where the cancer has spread. We also very much need to ask, will offering treatment after surgery improve outcome? Because the goal of any treatment is to reduce the risk of the cancer ever coming back. We have several cell types in endometrial cancer, and we can think about them in two different ways, low-grade cell types and high-grade cell types. And truly, the only low-grade cell types that are in endometrial cancer are endometrioid type, grade 1 and 2. Everything else is considered a high-grade cell type, and that includes endometrioid grade 3, serous, undifferentiated, clear cell, carcinosarcoma, as well as mixed cell types. I always like to take a minute and just make sure we understand that grade is different from stage. Sometimes when I speak with patients, they are concerned because they had a grade 2 or a grade 3 biopsy result and are concerned that they may be stage 2 or stage 3. These are totally different terms. So grade is what a cell looks like under a microscope, the cell type. Stage is where those cells have spread. So stage 1 endometrial cancer is cancer you only find in the uterus itself, has not spread anywhere else. Stage 2 is where that cancer has spread to the cervix. Stage 3 is where the cancer has spread nearby to the uterus, either on the surface of the uterus, the ovaries, the vagina, or lymph nodes. And stage 4 is where the cancer cells have traveled elsewhere in the body. And I'd like to just put a plug here. This staging information was provided with a very useful patient-based endometrial cancer user guide. The link is here below on the left from the Foundation for Women's Cancer. This slide, you do not need to drill into all, it's very wordy. There's a lot of text on this slide. What this really is a big picture view of how we generally think about treatment after surgery for early stage disease. So endometrial cancers that largely arise from the uterus itself and has not spread anywhere else. Low risk patients tend to have low grade cell type. They have not had much muscle wall invasion. And in these patients, we typically do not offer any additional treatment because again, it will not improve outcome, and we don't want to provide additional treatment in cases where we do not think additional outcome will be of use. Intermediate risk, again, low grade cell type with some muscle wall invasion, usually through the outer half. With no lymphovascular space invasion, we will offer vaginal radiation. This is local radiation in the vagina, 3 treatments, very much to reduce the risk of recurrence to the vaginal cuff, just at the top of the vagina, which is where most recurrence in endometrial cancer will be located. The next group, the high intermediate risk group, is an area that there has been a lot of research, a lot of discussion trying to find the optimal treatment plan for this group. And that is because if we don't provide treatment after surgery, the risk of recurrence is about 25%, or 1 in 4 women who have high intermediate risk endometrial cancer. And these are the women who have cancers that are grade 3 with muscle wall invasion or have lymphovascular space invasion. And these are patients that we will offer vaginal radiation, occasionally radiation to the whole pelvis to treat the lymph node region and areas outside the uterus. We do not have any certain benefit to chemotherapy, although there is some discussion about that. And finally, the high-risk patients are those who have grade 3 endometrioid with muscle wall invasion, or the cervix is involved, or the high-grade cell types, the clear cells and the serous cell types. These patients are offered or discussed to have pelvic radiation, and there is some evidence to favor chemotherapy, but this is very much still under investigation and not a standard of care. Dovetailing with that, here is a trial called ENGOT-EN2. This is a cooperative group trial that is still under analysis. Recruitment has been complete. And what this group is looking to answer is exactly that high-risk group I just discussed, where we're trying to determine if some of these patients would benefit from chemotherapy as opposed to the standard vaginal radiation. And so this trial is randomizing patients to chemotherapy with vaginal radiation versus vaginal radiation alone. And we're very excited about this trial because it may help further guide and tailor our treatment in this particular population. Now, we have relied on these risk factors I just discussed, the lymphovascular invasion, muscle wall invasion, the grade of the cell type, to help guide our treatment decisions and our counseling. But we're now moving into an era where molecular profiling of tumors, we're learning so much more about how endometrial cancer is really moving beyond those pathologic risk factors. And we're using sequencing not only to subtype our tumors, to group them, but also to figure out if they have specific molecular features that help us personalize the treatment strategy for individual women, either through clinical trials or targeted and immune therapies. And the bulk of this talk today is really reviewing that really exciting new information. The Cancer Genome Atlas is an important study to make sure we touch upon, because so much of what we do now was catalyzed by the work of these researchers who published their paper in 2013. The Cancer Genome Atlas is a multi-institutional research group that published the molecular profile of endometrial cancer. They had over 200 tumors. Most were endometrioid cell type, but also some were serous cell type. And they identified 4 different subtypes, major subtypes within endometrial cancers. First, an ultra-mutated POL-E mutation group. These are the cancers that have over 500 mutations inside of them, so an ultra-mutated profile. Second, in the green box, microsatellite instability hypermutated tumors that encompass cancer syndromes like Lynch syndrome, as well as mutations in genes that are involved in fixing mismatch repair errors in the DNA code. Additional studies were done that identified what we call copy number clusters, and 2 groups came from this analysis. The copy number low subtype, where we find most of our low-grade endometrioid cancers, and the final and 4th group, copy number high, was described where we find the serous cell types and serous-like subtypes of endometrial cancer. What really caught our attention from this paper and the results from this research was the survival curves you can see to the right across the 4 different groups that show each subtype had a very different progression-free survival, with the POL-E subtype in blue doing the very best and the copy number high in red doing much worse in comparison. And in the middle were the copy number low and microsatellite instability high groups. These results are what prompted us as researchers and doctors to see how this impacts our treatment decisions, how to target the groups that need better therapies, and how to implement testing of tumors so we can understand the subtype of each individual cancer to inform treatment decisions. With that in mind, this is a study that's still recruiting called PORTEC-4 that's looking at integrating molecular features into our treatment decisions in order to improve the outcomes for women. So this is taking a group of patients who would normally be eligible for vaginal radiation, a high intermediate risk group of endometrial cancer patients, and they're randomized 2-to-1, where the standard approach is the vaginal radiation, and the investigational approach is looking at whether they have a favorable, an intermediate, or an unfavorable molecular profile to help guide treatment. And this is largely because we think that there are groups of patients who may be overtreated or undertreated, and trying to utilize the molecular information to better guide and tailor the treatment. We'll move next into the treatment of advanced stage endometrial cancer. Now again, these are very general guidelines, really just to provide context for what is being thought about when a woman presents with advanced stage endometrial cancer or recurrent endometrial cancer. And I want to emphasize here that clinical trials are key, and we're always thinking about how to provide new approaches that are very specific to each individual woman when she may be confronting this particular disease. With regards to advanced stage endometrial cancer, women who've had no prior treatment, we consider surgery as long as the idea of resecting all the visible cancer is reasonable and feasible. Following this, chemotherapy is favored with carboplatin and paclitaxel as the preferred chemotherapy regimen. There are some circumstances where radiation is considered, and some circumstances where immune and targeted therapies are considered, and we'll talk about this through the talk. With regards to recurrent cancer, it really doesn't matter what stage a woman was when she was first diagnosed. Once the cancer has come back, we label this recurrent cancer. And what we think about, there's many different factors, but specifically, where has the cancer come back? Because the site of recurrence is important, whether single site or multiple spots, and whether she's had prior radiation also will matter. We consider surgery if it's reasonable and feasible, and we think it will improve outcome. We discuss and consider chemotherapy, radiation, hormonal treatment in the setting of recurrence, as well as immune and targeted therapies. We'll now talk about specific classes of drugs, groups of drugs and medications, how they work, and all in the setting of advanced and recurrent endometrial cancer. And we'll begin by talking about anti-angiogenic drugs. Some endometrial cancers make specific proteins that connect with receptors in blood vessel walls. Once these proteins bind to receptors, things called growth signals are communicated to the blood vessels to cells nearby. The binding and signaling is what helps the cancers build new blood vessels and gives the cancer access to oxygen and nutrition in the body. An anti-angiogenic therapy are drugs that block blood vessel growth in cancer and blocks the binding and signaling process. This can help stop or slow cancer growth. This is an active drug in endometrial cancer, both upfront in women who have never received any prior treatment, as well as in the recurrent setting. The very best responses are when it's used in combination with carbo and Taxol in the first line setting. Examples for those who either maybe have been treated with medications like this or even seen it in the media is a medicine called bevacizumab, also called Avastin, as well as lenvatinib, and there are many others. Hormonal treatments are reserved specifically for the endometrioid low-grade cell types. And hormonal treatments are where we use hormones or hormone blocking drugs to treat the endometrial cancer. And it's not the same as hormones that are given for menopausal symptoms. They're specifically used in the setting of recurrence where the cancer has come back after initial treatment. Examples include progestins, which slow cancer cell growth. And examples are medroxyprogesterone and megestrol acetate, also known as Provera and Megace. Tamoxifen, which is an anti-estrogen drug, works best when we alternate it with a progestin. Estrogen feeds cancer cells, and so by blocking estrogen, we're starving the cancer cells. And finally, aromatase inhibitors, which are drugs that block estrogen that's made in the fat tissue of our bodies, even after ovaries are removed or if we are menopausal. And examples include letrozole, anastrozole, and exemestane. The response rates are really best, as I mentioned, when alternating progestin with tamoxifen, but we can achieve response rates between 10 and 30% with single agents alone. More recent studies have looked at combining letrozole with something called everolimus, which is an mTOR inhibitor, a targeted agent. And this was a very promising study that showed not only an overall good response rate, but actually improved progression-free survival in women with endometrial cancer over our traditional use of progestin with tamoxifen. And that's an additional option to consider. So the next couple slides talk about the immune system and how we are using it to treat cancer. I think it's worth diving into this because in the end, we have to help all of us understand why we would use a certain medication when it's useful, because we're getting a lot of information that sounds very exciting in the media, but not drilling in enough, I think, in the specifics to help understand when it can be useful. And this is becoming an era in endometrial cancer where one size does not fit all. And I do think providing this additional information can be very empowering when digesting what's being presented in the media and digesting when you're speaking with your doctors about what treatments are appropriate for you and what treatments may be useful in a specific circumstance. So to talk about the immune system very generally, our body's immune system is a network and it helps to fight infection and disease in the body. And I have a funny cartoon on the left just to help us see visually. We've got lots of different cells called lymphocytes that work in the immune system. These cells can sometimes be recruited when there's mutations or mistakes in the DNA or code of a cancer. Our immune systems can see that. The more mutations that are in a cancer, the more likely it is that the immune system sees it. And we can actually see that these immune cells or T cells will surround the tumor trying to attack it. Some endometrial cancers have a very high number of mutations compared to normal cells in the body, and even if we compare them with other endometrial cancers. And these endometrial cancers with very high number of mutations are MSI high. MSI stands for microsatellite instability. These microsatellites are spots in our DNA that have what's called base pair errors. Base pairs are partners in the DNA code that belong together. You can see them highlighted in bright yellow on either side of this picture. Sometimes mistakes are made and they don't partner correctly, and the DNA mismatches, which happen all the time when we're replicating our DNA, don't get repaired because the mismatch repair proteins are mutated or not functioning properly. When that happens, the cell can't do its job, which leads to a very high number of mutations in some cancers. And this can result in getting a bunch of immune cells recruited to the tumor. If the microsatellite areas in the DNA code aren't fixed, the sites will start to change in length. They can get longer and they can get shorter than what we expect or predict. And this is what results in a microsatellite unstable tumor. And we actually now have tests that can help diagnose a microsatellite stable tumor from a microsatellite instability high tumor. When functioning properly, the T cells get activated in our body and attack a tumor cell. But some tumors sneak past our immune system through something called the PD1 pathway. Tumors have really special sites on their surface. You can see in the far left picture. These sites are called PDL1 and PDL2, and they can bind the receptor on that T cell and quiet the T cell, basically silence the T cell from doing its good job. And one medication called pembrolizumab, the brand name is called Keytruda, binds that PD1 receptor on the T cell, which stops the tumor from doing that work, from being sneaky and trying to quiet the T cell. And this gets the T cells revved up and allows them to attack the cancer cell. This particular medication is approved in MSI high or microsatellite instability high endometrial cancer in the recurrent setting, so in patients who've received prior treatment. Another really exciting medication is called trastuzumab or Herceptin. Some may have heard of this medication as it's also used in breast cancer. We'll talk about it specifically while we use it in endometrial cancer. Herceptin or trastuzumab is an antibody that binds something called the HER2/neu receptor that's found on the surface of a cancer cell. This will block the HER2/neu signaling the cell that tells it to grow and divide. It also may tag the cancer cell so the immune system can see it and destroy it. So it works a couple different ways. In serous type endometrial cancer, sometimes called papillary serous cancer, it is the less common cancer type, more common presenting in advanced stage disease, and does not respond as well to our typical chemotherapy or radiation treatment strategies. Therefore, outcomes are not as favorable, even in stage 1. And we specifically have been focused on this cancer type to find better therapies because of all of that. And one very unique feature about the serous endometrial cancers is that roughly half, a little over half, will overexpress that HER2/neu protein. And when it's made in larger than normal amounts, the cancer cells can grow more quickly. But because we have trastuzumab, it's also a targetable problem in the cancer. Dr. Fader, with the SGO 2020 webinar that covered novel discoveries in endometrial cancer, presented for her group the updated survival analysis of using a HER2/neu targeted agent, trastuzumab, with chemotherapy in women with uterus serous cancers. This is a trial that has been published, and she provided the updated survival information at SGO this year. And this is a trial that looked at women with serous endometrial cancers who expressed HER2, 61 patients, with advanced stage or recurrent disease. They were given either chemotherapy for 6 cycles, carbo and Taxol, or chemo plus trastuzumab with trastuzumab maintenance. So after their chemo was done, they still continued the trastuzumab. What they found was an improvement in progression-free survival with the addition of trastuzumab, with chemo alone showing a progression-free survival of 8 months compared to almost 13 months, a 5-month difference when adding trastuzumab. The authors also emphasized that this benefit appeared to be greatest in women with advanced stage disease, so receiving treatment in the upfront setting, compared to women in the recurrent setting, although both groups benefited from a progression-free survival standpoint. The update from the SGO webinar this year was about overall survival, and the long-term results of over 87 months of follow-up showed that the overall survival was significantly higher in the women treated in the trastuzumab arm of this trial, with 24.4 months overall survival with chemo alone, compared with almost 30 months with the addition of trastuzumab. This is a really exciting result to see an overall survival advantage in this group of patients. Another update with the SGO research presentation was presented by Dr. Vicki Macker from Memorial Sloan Kettering. And in her trial, she was presenting the results using a combination of lenvatinib, which we learned about earlier, an anti-angiogenic medication, with pembrolizumab, which is an immune checkpoint blocker. This is the study design. This looked at women with recurrent endometrial cancer, 108 patients, who had had 2 or fewer prior lines of treatment with disease that we could measure on imaging. This was an expansion from a phase 1 trial to a phase 2 trial, looking at response rates with pembrolizumab plus lenvatinib. You can see here, it's a busy slide, but we've highlighted in red the areas to focus on. Not MSI high, so these are microsatellite stable patients that were also included in this trial, 94 of them. So the majority of women studied in this trial were microsatellite stable. And those women showed a 38% objective response rate to this combined medication regimen. In the MSI high group, there was an improved response of 63.6%. Both response rates are very good in this population of women with recurrent measurable endometrial cancer. What's also very interesting and worth noting is the duration of response was not yet met in the microsatellite stable group, meaning there were many patients still responding to the treatment. This is a waterfall plot that is basically showing of the patients, each patient is a bar on this graph, and whether the patient's tumors grew or shrank. Going below 0 means they shrank. Going above 0 means they got larger. And you can see the vast majority, 85.7% of the patients in the study had tumor shrinkage. Over 30% had their tumors shrink by more than half, and 16% had their tumors shrink by more than 75%. These results were remarkable in this particular population of patients and led to the accelerated approval of lenvatinib plus pembrolizumab in 3 different areas: the FDA, the Australian Therapeutic Goods Administration, and Health Canada. Patients need to have had disease progression following prior systemic therapy who are not candidates for surgery that could be curative or radiation. And this is specifically for women who are microsatellite stable, not microsatellite instability high. Dr. Macker's conclusions, this is a slide from her presentation, stated that lenvatinib plus pembrolizumab was compelling in its activity with patients in advanced endometrial cancer progressing following a prior therapy. There were deep and durable responses to this 2-drug regimen, and the safety profile was similar to previously reported profiles of each drug alone. There was a slightly higher incidence of hypo or low thyroid in this study, but overall a good safety profile with a phase 3 trial upcoming to further confirm the results. And you can see here, this is our treatment compendium looking at approved agents in the treatment of endometrial cancer. And I've highlighted in red these new therapies that are now compendium guideline approved: lenvatinib, pembrolizumab in microsatellite stable endometrial cancer, pembrolizumab in microsatellite instability high endometrial cancer, and trastuzumab, also called Herceptin, in serous endometrial carcinomas. So looking to the future, we had a couple very interesting presentations at SGO this year that I wanted to highlight. The first was presented by Dr. Sabatier, Raynaud Sabatier, looking at an immune checkpoint blocker called dostarlimab in patients with recurrent and advanced mismatch repair deficient endometrial cancer. Remember, we talked about those mismatch repair genes. When they don't work, we end up with microsatellite instability or frequent mutations. And this is a specific subgroup type of endometrial cancer that we are targeting to better find more tailored therapies for. As I mentioned, dostarlimab is an immune checkpoint inhibitor, and this was used in recurrent and advanced endometrial cancer. This group was presenting specifically the box in orange, the mismatch repair deficient endometrial cohort. There were 104 patients analyzed, and they were specifically looking at outcomes called response rate as well as duration of response and safety. Most patients were in their middle 60s in this study. Most were white with a good performance status, overall healthy, fit people. Most patients had endometrioid cell types with a prior platinum-based, carboplatin-based chemotherapy regimen, and most had at least 1 or 2 prior lines of treatment. The objective response in this study was robust in patients with recurrent and advanced endometrial cancer who had progressed on a prior platinum therapy. There was 42% objective response rate, 13% completely responded, 30% had a partial response, 16% had stable disease. And as of the data cutoff in this study, 83% of patients were still responding. This is a graph showing treatment duration of responders. So time is moving left to right on the bottom of the graph, and patients are represented by the yellow bar graphs that you can see moving forward in time. With median follow-up of 11 months, the duration of response hadn't yet been reached, meaning people are still actively responding, with 83% of responders still in active response. And this other really interesting component of deepening of responses. So patients who initially had stable disease with the medication are now partially responded, 4 patients. And of patients who had a partial response to the medication, 7 went on to a complete response over time. Another very interesting finding with this medication. A final abstract to review from the Sto Novel Discoveries in Endometrial Cancer presentation was with Dr. Liu from the Dana-Farber Cancer Institute. And she presented her group's data looking at a phase 2 trial of something called a WEE1 inhibitor in uterine serous carcinoma. Just very briefly, serous cancers have mutations in something called P53. And when this happens, cells' ability to replicate and continue moving forward in the cell cycle is impaired. When you add something called a WEE1 inhibitor, it's acting at a different checkpoint in the cell cycle. And these two basically breaks in the cell cycle at checkpoints can basically contribute to a lethal response where the cell dies and can't continue forward, which for cancer cells can be a very useful strategy for treatment. This is the study schema. There were 16 initial patients in this study, and based on 2 or more responding to the treatment, the group was allowed to expand to an additional 19 patients receiving the study drug. There were 34 patients evaluated with a response rate of 29%. All of these were partial responders. 9% had stable disease over 6 months on treatment. The general conclusions from this group I would summarize as, this is a promising drug, but it's early days. It's great in that it's utilizing an unselected serous population, meaning HER2 status does not matter in this particular study. And the results are very interesting for a single drug, no combination, to have a response rate of 29%. Also of note is the progression-free survival at 6 months. Over 55% of patients had progression-free disease at 6 months in this study. And the authors have future studies planned for this medication, so I think we will see more in the future in this regard. We'll now briefly review 3 upcoming trials just to get a snapshot of what's coming down the line. So we covered a lot of these really exciting medications, pembrolizumab, trastuzumab, other PD1 immune checkpoint inhibitors in the recurrent and advanced stage setting. These next trials are actually looking at these medications and bringing it into the frontline setting, so at the time of initial diagnosis. And NRG-GY018 is one of those trials. This is an immune checkpoint blockade trial that's adding pembrolizumab to carboplatin and paclitaxel to our standard chemotherapy. And so women will be randomized to receive the standard treatment of chemo plus placebo versus the chemo plus pembrolizumab with pembrolizumab maintenance. This trial is looking at the combination of lenvatinib and pembrolizumab and comparing it to our standard of carbotaxol in the first-line setting in women with advanced stage and recurrent disease. So they are not receiving prior treatments before enrollment. This will be their first treatment, and they'll be randomized to our standard chemotherapy versus lenvatinib and pembrolizumab. And finally, the RUBY trial, which is a cooperative group trial looking at immune checkpoint blockade. And this is comparing dostarlimab plus carbotaxol followed by maintenance dostarlimab with carbotaxol plus placebo in the first-line setting in women with advanced and recurrent endometrial cancer. We have a long way to go, but I would say this is a time for all of us in the field where the idea that we've been able to move forward at all and have new medications that have proven efficacy for our patients in these specific subtypes of endometrial cancer that have been very difficult to find breakthroughs for. This is an exciting time, and there's even more up on the horizon. I thank you for your time. That's all the slides I've prepared, and I think we do have some time for questions.
Yes, thank you so much, Dr. Mueller. We're going to begin the Q&A now. You can still submit questions in the question pane in the control panel, and we'll try to get through as many questions as we can, but we may not be able to get through all of them due to time constraints. So let me just start, Dr. Mueller. There were two questions about serous uterine cancer. How many cases are there annually? And also, is CA-125 still the best marker for the serous cancers?
Those are great questions. So the way that we provide statistics, from the big like SEER data, usually groups endometrial cancer all as doesn't matter the cell type. But we do know that in the upfront setting, about 10% of endometrial cancers are the serous subtype. Now, for the CA-125 question, we will obtain CA-125. It is not a requirement, but in my experience, a CA-125 can be useful, particularly if it's elevated before surgery or before starting any treatment, and then that marker normalizes, goes to a normal range when treatment is complete. And because serous cancers of the endometrium are not exactly the same as ovarian serous cancers, we can't really compare them directly, but we have used the experience of ovarian serous cancers in that way by the addition of using the CA-125 marker. But it is important to share that CA-125 is not specific to serous endometrial cancer, and you can have active cancer without a CA-125 elevation, and you can have an elevation in CA-125 and no cancer. So it's just important caveats just to interpret that information.
Great, thank you very much. I had another question about radiation. How is radiation given to the uterine region, and what are the side effects? And also, how are those side effects treated if they do occur?
So the vast majority of women who are considering radiation for treatment after surgery will receive vaginal radiation. Vaginal radiation is delivered internally through a device that puts the radiation very much at the tip of the device. It's inserted into the vagina for a short period of time to deliver the dose to the top of the vagina. And this is done over 3 different treatments so that you get an accumulation of a dose that is appropriate to treat that specific area. Because we know most recurrences will happen right at the top of the vagina where the uterus used to sit before surgery, this is a strategy to reduce local recurrence in endometrial cancer. The actual side effects, if you're actually getting the treatment, are zero. You go in and you have the treatment and you go home. However, long term, because women are often having their uterus, cervix, ovaries removed, many are past the age of having periods, and so they're menopausal, combined with local radiation, something called stenosis or scarring of the vagina can occur. And in order to have adequate space for examinations during the surveillance period, sexual activity and comfort with sexual activity, we will often teach and reinforce the practice of vaginal dilator use, which can be, kind of ongoing past the completion of the vaginal radiation. So the predominant side effect can be narrowing of the vagina or shortening of the vagina. And we counteract that through education, sexual health teaching, and the vaginal dilator teaching. Now, that's very different from pelvic radiation. When I say pelvic radiation, it's really treating, if you look down at your body, it would be kind of at your hip bones down to your pubic bone is just the general area that we would target treatment. But it isn't that general. So you would meet with a radiation oncologist who would then perform imaging, typically MRI-based imaging, and they map out and literally they draw all of the spaces that they need to target, and then they narrow in the radiation dose to the areas that they are most concerned the cancer could return, while sparing radiation to the parts of the body that really don't need the radiation and won't benefit from it. So like the bladder or the intestines. The key areas in pelvic radiation to treat are lymph nodes and the area that is where the uterus used to be. And so this is a highly specialized, multidisciplinary kind of process of treatment. And you go in each day, 5 days a week, and you again accumulate a specific dose that will achieve the amount that you need to be therapeutic to get the radiation to where you need it to be. Hopefully that answers the question. Now, side effects to pelvic radiation, we think about it in terms of an early side effect and a later side effect. Early side effects are less common, but can be loose stools or changes in your bowel function, maybe some urgency with going to the bathroom. And this is all just sort of the very small amount of maybe watershed radiation that can trigger on the intestines and the bladder. Long term, you can have more concerning side effects, but they're very, very rare. And a radiation doctor goes through everything in detail before the radiation is ever given so that people are properly informed.
Great, thank you very much. I have a question about Keytruda, and do we see tumor markers rise at all if someone is on Keytruda, and would that rise indicate it's not working as well?
We, at this point, that's a great question, and it's getting into this concept of, do we have a biomarker? Meaning, do we have a blood test or something that we would say, we expect this to change and in response to how well the medication's working? And with pembrolizumab, or the brand name Keytruda, which is an immune checkpoint blocker, we don't have a specific blood test that we would be testing to say we think it's working or not. What we usually will do is a combination of symptom review, physical exam, and interval CAT scans or imaging to help assess whether the tumor is shrinking, staying the same, or in select circumstances if it's growing. And that's so that we're smart and we're not keeping with a therapy if it's not working, or we get the thumbs up that says the treatment is working and we should continue it.
Great, thank you. I had questions from 2 women about very specific types of cancer and whether these studies that are being done will impact them or be useful. One was somebody asking about stage 4 serous papillary with only CRAS mutation, and the other was somebody diagnosed with uterine Leiomyosarcoma. So if those two could be addressed.
Yeah, so stage 4 serous endometrial cancer, that would be when I have spoken in the talk about advanced stage endometrial cancer. Advanced stage is referring to stage 3 and stage 4. So the trial that I reviewed looking at trastuzumab or Herceptin with the combination of chemotherapy in women with advanced serous cancers, that is a trial. You always would need to check the HER2 status of the cancer, but that is a potential relevant study for someone with advanced uterine serous cancer. As well as, it's not ready for prime time, but at the end of the talk, the WEE1 inhibitor data that I reviewed that looked at advanced uterine serous cancers with a drug called adavosertib, that was HER2 status independent. And I will say, although we haven't gotten to ASCO's abstracts quite yet, but there are many researchers specifically focusing on improving outcomes and providing more treatment options for uterine serous cancers. So stay tuned on that, but we do have one compendium drug that's approved, trastuzumab, and several more in the pipeline. Now, the other thing to keep in mind is in Dr. Macker's trial, which looked at lenvatinib and pembrolizumab in endometrial cancers, there was a 40% response rate in the serous cancer patients in that trial to that 2-agent combination therapy. So that was a trial that didn't just look at the endometrioid cell type, it looked at serous and clear cell and endometrioid and saw activity for all of them. And that's a really important caveat to mention. Now for the leiomyosarcoma, that is completely outside of today's talk, and I think it's a good question because it can help clarify to the listeners that endometrial cancer is cancer that comes from the lining of the uterus. Sarcomas, including leiomyosarcomas, come from the muscular wall of the uterus, and it's a different, quote, family of cancers in the GYN tract. And they have a different paradigm and treatment strategy and ways to consider what's, the next steps in treatment for. So it's beyond today's talk, but a very important subject, and hopefully will be a webinar soon so that folks can tune in and learn more about that.
Okay, perfect. What is the probability of recurrence for the early stage 1 cancers, uterine cancers? Would you say somebody who is in good health and has had chemo and completed treatment and radiation and chemo?
One thing I would just bring the listeners back to is the slide where I said the general ways that we treat stage 1 endometrial cancer, and remember all the lots of words on that slide, and we talked about low risk and intermediate risk and high intermediate risk and high risk, and all of those were just uterine confined endometrial cancer. Now, in terms of prognosis and risk of recurrence, it's a tricky conversation to have because there's so much variability. Okay, who had muscle wall invasion and who had lymphovascular invasion, and how old is the person in front of me, and what treatment did they need and did they get it? And there's a lot of things that can go into that, and cell type matters too. But in general, what we tell folks is once you've completed treatment and it was curative, you will still have a risk of the cancer coming back. We have reduced it to the most we possibly can with the treatments available to us. And once you're in remission, you go into what's called surveillance. And what we see is that the vast majority of women who are diagnosed with an early stage, somewhere stage 1, stage 2, or even node positive cancers, their risk of recurrence is highest in the first 2 up to 3 years. And so we'll see them more carefully and more frequently in those first couple of years. but their risk will decrease as time passes, simply because we know that's when most of the cancers are going to come back.
That's very interesting. Thank you so much. I think we're actually have run out of time. So I wanted to thank you so much, Dr. Mueller, for such an interesting and informative program. And thank you to all of our participants and those who submitted questions as well. Please take a moment to fill out the survey at the end of the webinar. It may take a minute or two for the survey to download. So when you leave the webinar and exit, you will get the survey and soon after that. So thank you again to everybody, and we look forward to having you join us again for another webinar. And have a good rest of the day. Thank you again.